Welcome everyone, and thank you for joining us today for our first webinar in our Lewy Body Dementia Caregiver webinar series. Today we're very pleased to have Dr. William Mantyh present What is Lewy Body Dementia and How is it treated? I've had the privilege of working with Dr. Mantyh, and I've been really impressed by his knowledge and practice, and I'm very grateful that he's here with us today to share his knowledge. I ask that you please type your questions in the Q&A box below. We ask that you ask general questions, as we won't be able to respond to questions about individual cases. And without further ado, we'll go ahead and let Dr. Mantyh take over. Thank you.
All right, welcome everybody. Thanks for tuning in today. We're going to be talking about Lewy body dementia, what it is and how it is treated. So just a quick introduction on myself. I was raised in Minnesota and I went to Mayo Clinic for my neurology training. I then came to much warmer and sunnier California, where I performed a fellowship in behavioral neurology at University of California, San Francisco. My background in Lewy body dementia, I've hosted several support groups at Mayo Clinic in Rochester. And my research, although it primarily focuses on Alzheimer's disease, has a lot of overlap with genetics of Lewy body disease and how the genetics of Lewy body disease can inform our understanding of dementing illness in general. So the topics that we're going to cover today, we're going to talk about the symptoms and the diagnostic criteria of Lewy body disease. We will also talk about some of the dysautonomic symptoms, and that's sort of a mouthful, that word dysautonomic. So we're going to explain that in more detail later. We're also going to talk about how this disease progresses over time, from sort of how patients initially show symptoms all the way to sort of the more severe end stages of this disease. We're also going to talk about our current understanding of the risks, such as environmental risk factors and also genetic risk factors that might predispose someone to developing this disease. And then finally, we're going to wrap up with currently available treatment approaches. So Lewy body dementia is sort of an umbrella term. It involves more or less the buildup of a pathological protein called alpha-synuclein, which we're going to talk about later in more detail. But this is a protein that's associated with numerous diseases. And in particular, it can cause what's called Lewy body dementia, or dementia with Lewy bodies. And it can also cause Parkinson's disease dementia. And these are kind of two sides of the same coin. So the real difference is whether symptoms like balance and one's ability to walk, whether deficits in those areas preceded or came after the deficiencies in cognition. So for instance, in dementia with Lewy bodies, the first symptoms are more or less cognitive symptoms, whereas in Parkinson's disease dementia, the first symptoms are going to be symptoms of Parkinson's disease. So tremor, slowness of movement, predisposition to falls. But these diseases, again, they share the same underlying type of abnormal protein, and so they're part of the same supergroup. So overview of symptoms and diagnostic criteria. So this is a disease that really varies quite a lot from patients to patients. And I think we've all heard the saying that everyone is unique. And that saying really applies here in the setting of dementia with Lewy bodies. So people present with different symptoms all the time. However, there are some common symptoms that occur quite frequently in this disease. So one of the key symptoms of this disease, again, it doesn't happen in everyone, but many people with this disease have this symptom, are visual hallucinations. So these types of hallucinations typically take the form of non-threatening people or animals. For instance, I've heard caregivers or the patient describe seeing a deceased loved one at the foot of their bed, or seeing a choir of children come in and stand in their room. I've heard of people saying that they live with a squirrel who stands on the windowsill and looks at them. Fortunately, these hallucinations are typically non-threatening, although sometimes these hallucinations can turn into something that is quite distressing for the patient. With this disease also occurs relatively frequently what I will call supernatural experiences. So many times people have this unmistakable feeling of having someone in the room next to them. They describe it as if they feel a presence almost of a being or someone that's sitting next to them, even though they know that they're not there. It's sort of this paranormal experience that people go through. This disease also, by definition, has cognitive impairment. So unlike traditional Alzheimer's disease, which causes mostly impairment in memory functioning, this disease typically causes impairments in one's ability to organize, to multitask, or problems with visual spatial skills like parking a car or lining up furniture in the right direction. This disease also commonly affects patients by causing what we call dream enactment behavior. Dream enactment behavior is more or less qualified by when patients have typically a frightening dream and start to act out the dream while they're sleeping. For instance, they'll flail their arms or their legs. The caregivers frequently report yelling and screaming and curse words. Typically, it's only the scary dreams that kind of break through the body's ability to suppress the dream activity from coming out into real life. With this particular disorder, it affects that normal mechanism that people have where if they dream something scary, they're not going to act it out in sleep. So in this particular disease, patients frequently will, as I mentioned, flail their legs. Sometimes they even push themselves or kick themselves out of bed, hit themselves on the nightstand, or even fall onto the floor. I've had some patients who dream of catching a football and jump out of bed and hit their head onto the closet. So this is something that is actually quite dangerous for patients. And it's also a sign that's actually quite specific for the entity of Lewy body disease. Along with other sleep problems, patients frequently have alterations of consciousness throughout the day. So patients frequently have an irresistible urge to nap, or almost what looks like spacing out, where it's very difficult to have them come out of this almost daydream-like state. And so those fluctuations in the level of consciousness of a patient are also characteristic of this disease. This disease also features a lot of psychiatric symptoms. In fact, some of the first symptoms of this disease can be depression or anxiety. This disease also features more strong psychiatric features like paranoia, thinking that people are out to steal from them or are out to do them harm. There's also a very specific type of delusion associated with disease called Capgras delusion. And what this is essentially patients, they feel like family members or people that they know are actually imposters that are disguising themselves as their family members but aren't their true family members. And this is called a delusion of misidentification that is quite specific to Lewy body disease. There's also, as I mentioned, disturbances of the autonomic nervous system, which we're going to talk about in more detail in the next section. So for instance, patients frequently complain of constipation, bladder spasms, erectile dysfunction, or dizziness when standing. And these symptoms can also precede the cognitive symptoms by many years. And then this is a disease that, as I mentioned, overlaps quite a lot with Parkinson's disease. And so patients with Lewy body dementia frequently show signs of Parkinson's disease, which is, if you watch a patient with Parkinson's disease walk, they appear to have a stooped posture. And when they walk, they appear to kind of shuffle their feet one in front of the other instead of walking in a more fluid manner. And generally, patients with Parkinson's disease show slowed movements. They have a tendency to fall, especially when they're in a precarious situation. Their voice gets softer, and they have decreased facial expression. So all these features of Parkinson's disease are frequently also seen in dementia with Lewy bodies. So kind of going forward now with what we look at when we diagnose this condition, how does a doctor look at a patient, assess them, and come up with a diagnosis of Lewy body disease? So there are clinical criteria that have been put forth by experts in dementia with Lewy bodies. And the core clinical features of this disease, so these are features, again, that are commonly seen and that are quite specific for dementia with Lewy bodies, are fluctuating cognition. So again, that's where patients appear to space out, or they appear to have a decreased level of alertness, or this might be reflected by a patient wanting to have an irresistible urge to nap that fluctuates during the day. Another core feature of this disease are recurrent visual hallucinations. And as I mentioned, this rapid eye movement sleep disorder, that was the dream enactment where people start to act out their dreams. And then, as I mentioned, Parkinsonism. So having any of the features of Parkinson's disease. Bradykinesia is just a fancy word for slowed movements. Rest tremor is when they have that, what is frequently called a pill rolling tremor, as if their hand is holding a pill bottle and they're rolling it. And then rigidity is when you move these patients, they're frequently stiff. And those are all features of Parkinson's disease that is frequently shared by patients who have dementia with Lewy bodies. And then the other features of dementia with Lewy bodies that we've touched on that doctors use to diagnose this condition. So sometimes patients are exposed to antipsychotic agents. And we'll talk about this a little bit more later in the talk. But patients, when they're exposed to these drugs, they can deteriorate very fast. For instance, a lot of the antipsychotic medications block dopamine. And one of the major deficiencies in the brain of people with dementia with Lewy body is that they don't have enough dopamine. And so when you add insult to injury, when you reduce dopamine in a brain that's already starved of dopamine, you can cause a lot of problems. And so patients with this entity are frequently extremely sensitive and can show extreme deterioration when they're given antipsychotic agents. The other features, as I mentioned, balance is an issue, so postural instability, repeated falls. Syncope is basically a fancy word for passing out. So a lot of people have trouble maintaining their heart rate, and that goes into those symptoms of dysautonomia, which again, we'll touch on in more detail later. But patients with any type of alpha-synuclein disease, which are the Lewy body diseases, so dementia with Lewy bodies, or Parkinson's disease dementia, have deficiencies in that autonomic component of their nervous system. And that applies to the heart, that applies to standing up and not passing out. So patients frequently have problems with this. And then patients frequently complain of hypersomnia, which is a fancy word for too much sleep. So patients will sleep much more than they used to. In the extreme cases, I've seen patients sleep the majority of the day. Sometimes caregivers say that they sleep for 20 hours in a given 24-hour period. So a lot of patients suffer from too much sleep. And then hyposmia is a fancy word for decreased sense of smell. So a lot of patients with this disease, they have part of their brain called the olfactory bulb, which is affected by the abnormal Lewy bodies, and that part of the brain degenerates, and you can have a decreased sense of smell. I mentioned hallucinations in visual modalities. So as I mentioned, seeing little people or animals, but patients can also complain of hallucinations in non-visual modalities, such as auditory hallucinations, frequently hearing music. At the extreme end, they can hear threatening auditory hallucinations from persecution, that they feel like someone is yelling at them or belittling them. And then, as I mentioned, delusions can be prominent in this disease. And one of those delusions being this delusion of thinking that loved ones, friends, family are essentially these imposters that are dressed up or sort of pretending to be their family. And then finally, apathy, anxiety, and depression. So kind of going forward, if a doctor sees 2 or more of the core clinical features, that is enough to diagnose someone with probable dementia with Lewy bodies. However, let's take the scenario where there was only one of the suggestive features of Lewy body disease. That would essentially fit into the possible dementia with Lewy body feature if there was an additional biomarker present. So going into the description of dysautonomia and what that means. So I kind of like to use the mnemonic that dysautonomia applies almost to a deficiency in the automatic nervous system. So Lewy body dementia not only affects the brain, but all of the nerves that come off of the brain, that come off of the spinal cord, and that basically send signals to the automatic parts of your body. So your heart rate changes and is dictated by your brain and by the nerves that come off of your brain and your spinal cord. And so those nerves can also be affected. And so people have deficiencies in things that are totally out of our own conscious control. So those automatic parts of our nervous system. So this can um, be your intestines, as I mentioned, your heart, your bladder, your sweat glands, and that can result in a multitude of symptoms. So when you don't have the right signals that are going to your heart or are going to your blood vessels, when you stand up, the normal tendency is for gravity to take your blood and shift it down your feet. But when you don't have a functioning automatic or autonomic nervous system, that blood essentially stays in your legs and leaves your brain and causes people to feel lightheaded and sometimes results in them passing out. Patients with Lewy body disease frequently have abnormal heart rate control. So they don't have the normal heart rate response to when they're exercising or when they're hot. Patients with this disease also sometimes have constipation. And sometimes constipation precedes the onset of brain disease by many years. And that's, again, the nerves that normally tell the intestines when to contract and when to move forward and when to defecate. That's a coordinated system of neurons that need to play together and move together in order to have a successful bowel movement. And those neurons are also affected in this disease, resulting in constipation. Patients also frequently have urinary spasms from basically a dysregulated bladder. So urination is actually a very complex process that involves relaxation of several different gates, basically, but also squeezing of the bladder to force the urine out. And that complex coordination of neurons is also disrupted in these diseases. Another early feature of this disease is erectile dysfunction, which is another automatic function of the human body that is outside of our control. And then finally, the sweat glands in our body are also innervated, or they have neurons that tell them when to sweat. And patients with dementia with Lewy body or Parkinson's disease dementia, they can have difficulty sweating when they need to. And so when they're exposed to hot environments, they can frequently overheat, and that can be a major problem. So dysautonomic symptoms are frequent in this disorder and are something to look out for. So what is the general disease progression? How does this disease start and how does it progress over time? So there's a general consensus that this disease probably develops over the course of decades. So for instance, we have seen patients who have some of these early features of dementia with Lewy bodies or Parkinson's disease dementia, who, for instance, have new constipation when they're 30, or who start acting out their dreams when they're 30, or who lose their sense of smell when they're 30, and then who decades later develop cognitive symptoms like difficulty organizing or difficulty performing complex tasks. So it's thought that this disease spreads very slowly over decades. So by the time that someone is demented, they're actually sort of at the later stages of the disease process. And once someone is demented, the median survival is about 5 years, which is faster than typical Alzheimer's disease. At the sort of end stages of this disease, patients typically show worsening signs of Parkinson's disease. So they get slower, they have greater difficulty walking, they have a higher chance of falling, they have more imbalance, and visual hallucinations and delusions persist and sometimes get worse to the point where people with this disease frequently get very paranoid about people's intentions around them. As I mentioned, they can have delusions that people are stealing from them, or delusions that their family members aren't their real family members. And one of the number one causes of death in this condition is that normal swallowing mechanism. So we all unconsciously swallow every minute many times, and that's basically to keep saliva from pooling in our mouth. And that normal sort of automatic swallowing mechanism is not intact in these patients, and instead of swallowing the saliva, sometimes the saliva slips down into the lungs and can create a bacterial infection leading to a severe pneumonia. So pneumonia is the #1 cause of death in these individuals, which is likely caused by a deficiency in automatic swallowing. So current understanding of the causes and risks in this disease. So what is Lewy body disease caused by? The short answer is we still really don't know the answer to this question. There's a lot of investigation that is currently underway. One thing to talk about more is what is alpha-synuclein. So Lewy body disease is associated with these microscopic deposits of a piled up alpha-synuclein. And we'll look at this in the next slide, but basically a Lewy body is a conglomeration of alpha-synuclein that you can see under the microscope. And this was actually named after the German neurologist who discovered them in 1912. And one thing to mention is that we don't know if Lewy bodies are really the cause of this disease, or whether they're maybe part of the disease process, or maybe are they a protective factor, but are still associated with the disease, somewhat how police are found at a crime scene, but the police might not have been involved in the actual crime itself. So we still don't really know the cause, the effect of Lewy body disease, of Lewy bodies in these different conditions associated with alpha-synuclein. So here's this is what Lewy bodies look like if you're looking under a microscope. So the blue dots you're seeing, those are cell nuclei. And the brownish stain, that is alpha-synuclein. So you can see that there are clumps of brown that build up right next to the different cell nuclei. And those are Lewy bodies. You can see that there's a little bit of smudging of brown in the areas between the nuclei, and those are called Lewy neurites. So the Lewy bodies are composed of alpha-synuclein, and sometimes the alpha-synuclein not only accumulates next to the nucleus, but sometimes they invade the parts of the nerve that branch out, called the dendrites or the axons. So this is a condition that builds up in the neurons, in the cell body of the neurons, and in the branching out parts of the neurons as well. So as I mentioned, most cases of Lewy body disease have no known cause. There's some evidence that there might be increased risk for Lewy body disease if one is exposed to certain toxins, especially early in life. However, not much is really known about this, as there haven't been any comprehensive or thorough studies. Finally, a minority of cases, probably about 5% of Lewy body disease, is caused by a known genetic mutation. One important thing to keep in mind, though, is that the human genome has 3 billion base pairs, or 3 billion essentially discrete pieces of DNA. And that's a lot of DNA to process. And so the genetic revolution is currently underway, but we still haven't sequenced a lot of the genome when it comes to looking at what areas are associated with Lewy body disease. So I think in the next 10 or so years, we're going to see that a lot more of the genome can predispose to Lewy body disease. So going to the environmental risk factors, as I mentioned, there haven't been any conclusive studies on this, but some doctors have looked at patients with these types of exposures and have hypothesized that they may increase the risk of Lewy body disease. So having a history of traumatic brain injury is thought to increase the risk of Lewy body disease. How that happens, we still don't fully understand. Reduced levels of dietary and sunlight-derived vitamin D, a history of midlife migraine with aura, living in urban or in industrial areas with high exposures to copper, manganese, or lead. There have been certain hydrocarbon solvents like trichloroethylene, which increase the risk for Lewy body disease. Living in rural areas also, unfortunately, may increase your risk of Lewy body disease. Farming or agricultural work, well water, high dietary intake of iron, especially in the combination with high manganese intake, excess body weight, type 2 diabetes, metabolic syndrome. Higher levels of education, for some reason, has also been associated with increased risk for dementia with Lewy bodies. And then lower muscle strength in late adolescence has also been associated with this condition. So a lot of different factors that we still don't fully understand. We've seen several veterans come to us who have been in the Vietnam War and who've had exposure to Agent Orange, also asked the question of whether that's been associated with increased risk for Lewy body disease. And there's some suggestion that that is the case. But as I mentioned, we haven't had the opportunity to design a truly thorough study to investigate that question. So genetic risk factors. So what are the genes that predispose someone to having this condition? So there's some thought that these abnormal proteins, that alpha-synuclein that you were looking at that aggregates or piles up into Lewy bodies, is the cell not taking out the garbage basically? Is alpha-synuclein kind of more or less the trash and the cell's garbage disposal men aren't taking the trash out? So there's some evidence that that type of pathology might be at play, that genes involved in what's called the lysosome, which is sort of the garbage disposal system of the cell, is deficient. There's also some evidence that genes involved in the cell's energy production are lost. So for instance, some of the cells that require a lot of energy, like the cells that produce dopamine, making dopamine is a energy intensive process, that those cells might have deficiencies in their energy production ability. There's also the idea that alpha-synuclein, it occurs as a normal protein in the human body. It's expressed in neurons to help with neuron-to-neuron communication. But is there something that happens to alpha-synuclein where it folds in the wrong way? And essentially it creates a misfolding that then sort of spreads the misfolding to other proteins. It can almost be thought of as a zombie protein where one protein sort of misfolds and then turns normal other proteins into the misfolded form, kind of like a zombie would turn normal people into zombies as well, sort of self-propagating the problem. Genes involved in misfolding of alpha-synuclein, that's what we just talked about, but as I mentioned, there's other kind of misfolding processes that could be at play that we're currently investigating. So current treatment approaches, what could be done about this disease? So sadly, there still is no existing treatment to stop or slow this disease. This is sort of a harsh reality that we live in. The only exception to that is physical exercise. So we still don't exactly know why physical exercise reduces the risk of developing this disease, but study after study has shown that physical exercise on average decreases the risk of developing Lewy body disease by about 30%. Also, if you have this disease, it slows down the rate of progression also by about 30 to 50%. So exercise is good for preventing this disease. It's also good for slowing down this disease. As I mentioned, we're not sure how exercise does this, but we think that when you have aerobic exercise or oxygen flowing to the brain, that it releases brain factors that help neurons survive. As I mentioned, though, one of the big problems with any of these Lewy body diseases, whether it's dementia with Lewy bodies or Parkinson's disease dementia, is that patients frequently have difficulty balancing and frequently walking. So patients frequently ask me, how am I supposed to get exercise anymore? And that's difficult, but patients and family members can sometimes get creative and do things like pool therapy or get a stationary bike, exercises that don't require as much balance as getting out and walking. So other medication approaches. So the go-to drug for helping cognition in dementia with Lewy bodies is an acetylcholinesterase inhibitor. So that's a mouthful. So what is an acetylcholinesterase inhibitor? So the brain has a neurochemical called acetylcholine, and it more or less helps people stay alert. It's actually one of the compounds in cigarettes. And obviously, we don't recommend cigarettes at all. It has a whole lot of terrible things in it. But one of the things that cigarettes has that helps people maintain alertness is it has acetylcholine. And that's, as I mentioned, a naturally occurring neurochemical in the brain that helps maintain attention. A lot of people think that it helps maintain focus. And that can help out with this particular condition where patients are deficient in this particular neurochemical. It can also help out with other symptoms aside from cognitive symptoms. It can help out with hallucinations, reducing those. It can also help reduce delusions as well. And there are numerous types of medications that boost acetylcholine in the brain. So the most common one is called donepezil. The trade name for that is Aricept. And then other less common but frequently used medications, galantamine and rivastigmine. And all these medications work by boosting acetylcholine. However, this medication can cause problems. Acetylcholine is also the neurochemical that's responsible for essentially contracting the GI tract and contracting the bladder. So when you give this medication, there's an increased tendency for the GI tract to contract, and you can have nausea, vomiting, diarrhea. Patients frequently complain of urinary frequency with this drug. Acetylcholine is also the neurochemical that the brain uses to tell the heart when to slow down. And so this can slow down the heart rate and lead to fainting. So this is this is a medication that has benefits for patients with this condition, but at the same time, it's important to consider some of the side effects, which are normally quite mild, but some patients, unfortunately, are forced to stop this drug because of those side effects. One of the other complicating factors of this disease, as we talked about earlier, are psychiatric symptoms. So delusions that people are out to get them, delusions that people aren't the real person that they appear to be, delusions that people are stealing from them. So these types of issues are dealt primarily with acetylcholinesterase inhibitors. That's the same drugs that we looked at in the last slide. However, if those drugs don't work, there are several other medications that doctors can try to use. So one of them is called pimavanserin, and that's a recently approved drug that is quite expensive, but there's been some evidence that it helps reduce psychiatric symptoms of this disease. And the way that this drug works is that it essentially acts on the serotonin neurotransmitters. It essentially activates the serotonin receptor in a way to help reduce symptoms of psychiatric disease. However, this drug also has some side effects to be aware of, such as a dangerous heart rhythm. It can also increase mortality, and that's one of the reasons that the FDA put what's called a black box on the label of this medication. And then two other drugs that are sometimes used, and these drugs are different than pimavanserin. Instead of acting on serotonin, they act on dopamine, and these drugs block dopamine. And as we mentioned before, blocking dopamine is sometimes a very bad idea in this disease because these patients are already deficient in dopamine. We don't want to add insult to injury. But sometimes when these patients are having severe psychosis, to the point of being combative or hostile, sometimes it's necessary to use these drugs. These drugs, again, they block dopamine. They can cause sleepiness. They frequently help patients calm down. One of the problems, as I mentioned, is that in these patients that already lack dopamine, when you take more dopamine away, they can worsen slowed movements. They can cause confusion. And similar to pimavanserin, they can increase mortality. For clozapine in particular, that is a drug that is stronger than quetiapine, but clozapine has a potential serious side effect of essentially crashing your immune system, and that happens in about 1% to 2% of patients. So it's important that if you're on this medication to check your immune system regularly with your doctor so you can realize if it's affecting it before it totally crashes. So another issue with these diseases is that patients frequently have either too much sleep or they sleep at the wrong time of day. They sleep during the daylight periods instead of the night period. Patients frequently have issues with dream enactment. So one of the medications that helps establish a normal sleep-wake cycle and also help with dream enactment behavior is melatonin. And that is a drug with almost no side effects that's very safely tolerated. It's a naturally occurring hormone in the human body. And patients can take that again to sort of help establish a normal sleep-wake cycle and to reduce the severity of dream enactment. Trazodone is a more heavy-hitting medication. Um, it acts on the serotonin system. It's also a medication that can help with depression, so it can be a little bit of a dual-acting medication. However, this is a medication that can cause sedation, dizziness, dry mouth, and nausea. And some patients feel that it might cause them to be a little bit too sleepy, and so that can be reflective of patients feeling like they're just not as sharp as they used to be. So it also unfortunately has the side effect of making cognition a little bit worse. Another common issue with these diseases is depression and anxiety. As I mentioned, these can sometimes herald the onset of disease. There are a lot of patients who come in who have new anxiety and depression when they've never suffered from these previously in life. And this is a major problem in these diseases. And so we treat anxiety and depression similar to how we would treat patients without Lewy body disease. We give them selective serotonin reuptake inhibitors. So the two that we prefer at our institution are escitalopram and citalopram. These medications have mild side effects and are generally very well tolerated. The side effects can include mild gastrointestinal disturbance, sometimes sleepiness, but sometimes patients paradoxically complain of insomnia. And then another medication to consider, especially for people who have symptoms of Parkinson's disease, is Sinemet. So Sinemet is basically dopamine. The reason it's called carbidopa-levodopa is because they modified dopamine so that it would cross the blood-brain barrier, and they added another drug to essentially prevent the natural breakdown of dopamine. So it's essentially dopamine on steroids, kind of. It acts on the dopamine system. It helps to improve movement speed. Some of the side effects, though, it can cause sedation. It can cause lightheadedness when standing. Some dopamine agents, they kind of worsen psychiatric disease. So some patients feel like it worsens hallucinations. It can worsen delusions. Dopamine is the neurotransmitter that's naturally involved with risk and reward in humans. So if you do something that gives you a lot of reward, there's going to be a lot of dopamine that gets released by the brain. And so patients with this medication who have more dopamine being released can sometimes participate in risky but rewarding behaviors like gambling. And they can frequently pick up a gambling habit when they used to not have any problem with gambling. And this applies to other kinds of addictions as well: alcohol addictions, drug addictions, sexual addictions as well. Physical therapy and balance therapy should definitely not be overlooked. So I've had a lot of patients who've had even Parkinson's disease for several years come in and still be able to walk as if they were walking on a tightrope. And that's a skill that's very difficult, but they go to physical therapy, or at least perform physical therapy exercises on a regular basis. And so you can sort of train that balance area of the brain to prevent the deterioration in balance skills. Another problem with dementia with Lewy bodies and Parkinson's disease dementia is that patients frequently have a very soft voice and sometimes have difficulty enunciating to the point where it might even be difficult to understand them or hear them. And so one therapy available for that is called big and loud therapy. And this is kind of like physical therapy, except physical therapy for the voice. And so these therapists improve how loud people can speak and how well they can articulate. And again, I've seen major transformations in patients not being able to really say anything loud enough for people to understand, to then going, 6 weeks later after this therapy and being able to have a normal conversation. So again, some areas of the brain are able to be trained and counteract some of the problems of these diseases. Things to avoid. So this is also something not to overlook. So I've talked a lot about how brains of people with Lewy body disease are deficient in dopamine, and how it's important to realize that it's only under absolutely necessary circumstances to give them something like an anti-dopamine drug. So we talked about those two drugs, quetiapine and clozapine, that can sometimes be used, but something to absolutely avoid are what are called first generation antipsychotics. So the names of these drugs, Haldol or Risperdal, are the two most commonly used ones. And the reason I say this is because a lot of patients with these diseases, as I mentioned, they can get very psychiatrically disturbed. They can sometimes become hostile and aggressive. Sometimes they have to go to the emergency room to get medications to calm down. And if you have an emergency room physician who's busy seeing 10 other patients and all they need is for your loved one to settle down, sometimes they won't have time to look through the whole medical history and give them something like Haldol or Risperdal that can really be a problem and cause patients essentially to stop moving altogether. And that can result in a lot of complications. So it's important to maybe even ask your primary doctor to list these medications as an allergy, so that if they're in an emergency situation and go to the emergency room, that's easily available to the providers there. Another thing to avoid in these patients are sedating drugs. So, as I mentioned, sleep can be a problem, and allergies can be a problem in people. But it's important to realize that medications like Benadryl or allergy medications can cause patients to be very sedated and very confused. So it's important to stay away from medications that are sedating. Finally, there are some non-medical approaches. We've talked about physical therapy and big and loud therapy, but there are some other non-medical approaches that can be useful for patients with this condition. So a lot of times, just doing some detective work, trying to identify what is causing patients to be agitated. So there was a patient who I saw who got very agitated when they saw themselves in a mirror, and would be very agitated basically when they went into the bathroom. And the caregiver didn't really know why the patient was so hard to bathe and so hard to perform teeth brushing on. And it was only after some investigation that we realized it was really their reflection in a mirror that was causing the main problem. And the resolution to that was basically taking the mirror out, and the patient was then able to perform their hygiene normally. So sometimes it takes a little bit of detective work to figure out what are the things that are provoking bad behaviors, or anxiety or other undesirable behaviors in these patients, and to essentially remove those bad stimuli from their environment. Another thing to realize is that if you remove a patient from a familiar environment, if you go on a trip, for example, or if you go to an unfamiliar store, this causes a lot of anxiety in patients because they're not grounded in things that they're normally used to. And that anxiety can lead to a lot of confusion, and it can lead to a lot of agitation. So it's important to know that when you're changing into an unfamiliar environment, to at least be prepared to sort of deal with those issues. And then, as I mentioned, providing a routine sleep-wake cycle is very important. So in the morning, make sure that the patient is able to get to a window and have a lot of bright natural light, that the curtains are completely drawn open. If you're not next to a window, there are numerous happy lights, so these very bright lights that people use, especially in very northern areas of the world, to sort of get the amount of light that their brain needs to realize that it's time to wake up. And then when it's time to go to sleep, shutting off backlit lights that fool the brain into thinking it's daytime. So you want the brain to have the normal, natural kind of stimuli to realize that it's time to sleep. So shutting off bright fluorescent lights or backlit screens. I've had patients read their iPad before going to bed, and they say, doctor, I can't get to sleep. Those patients benefit from having that iPad taken away 2 hours before sleep. And if they really need an iPad, you can get filters to take away the blue light. So it's important to kind of have those basic instinctual light exposures, sort of how they should be in order to regulate the sleep-wake cycle. And then finally, music therapy has proven beneficial. Pet therapy has also proven beneficial in certain patients. So there are kind of other approaches. So that's all I had to say today. I wanted to acknowledge all the support that we receive, without which we couldn't do any of the studies and projects that we're performing. And I think we'll open it up to questions right now.
Thank
Okay.
you. And for participants, if you look at the bottom bar of your screen, you should see a Q&A section. And we have one question so far, but if you are a participant and you have a question, go ahead and type your question in there. So our first question is regarding the genetic risks for Lewy body dementia, and they're asking about GBA mutations as a high risk factor for inherited Lewy body dementia.
Yeah, that's a really sort of cutting edge question because that's receiving a lot of attention these days. So GBA, for those in the audience, is glucose ribosydase. And if you have two of the bad, so everyone inherits one gene from their mom, one gene from their dad. If you kind of lose the genetic lottery and you get two of the bad GBA or glucose ribosydase genes, you can get a condition called Gaucher's disease, which is more or less um, a terrible disease to have. Patients frequently die when they're very young. It's sort of what's called lysosomal storage disease, where the brain cannot process certain types of fats. And so you have fats that accumulate in different areas of the body, whether it's the brain, the liver, the spleen, and those fats cause those organs to enlarge and essentially die. That's when you inherit two of the bad alleles, and as I mentioned, that's sort of the worst case scenario. The second worst case scenario is when you inherit just one of the bad genes. So in that case, you don't get Gaucher's disease, you don't get this infantile form of fat storage disease, but you're increased risk for developing a disease like Parkinson's disease. And that goes back to sort of the point I was talking about with lysosomal genetics in Parkinson's disease. So is it the cell's garbage disposal system that's not working? Is the cell not taking out, and processing proteins that should normally be degraded? And glucose ribosydase, or GBA, is one of those key kind of garbage men of the brain. It's involved in the lysosome, and it's involved in breaking down fats. And we still don't really know how this works, but for some reason, that particular gene, if you have one of them, increases your risk for Parkinson's disease. So yeah, there's a lot of kind of studies that are spawning from that, and maybe even trying to screen patients with Parkinson's disease to see if they have a GBA gene. And there's some clinical trials going on right now. I don't know what stage they're in. I think they're in very early stage, maybe even stage 1. So more or less safety trials at this point, not treatment trials, which are looking at targeting GBA and trying to, if you have one of the mutations, trying to take out that mutation and giving you the good mutation so that the disease stops. So yeah, it's a very interesting question. There's a lot of research going on in that area, but we still don't quite know why do you develop alpha-synuclein in Lewy bodies when you have, this enzyme that normally processes fats and degrades fats. So, but yeah, more to come. Stay tuned.
Glad you were able to answer that question. We all learned a lot. There's another question about, you referenced physical exercise preventing or slowing the progression of Lewy body by 30 and sometimes 50%. There's a question about having a reference to share with families about that. Maybe we can send it out over email.
Yeah.
We can send a reference
Yep.
over email. And there were a couple of questions, just people asking if this recording will be available. Yes, this is being recorded and it will be posted on our website. And I'll also send a link to participants over email. I wonder if we had a question over email about access to drugs that are being studied. I wonder if you can just talk about how to find clinical trials for this disease and where people might go.
Yeah, so the Michael J. Fox Foundation has a lot of drugs which are available for Parkinson's disease. But like I said, dementia with Lewy bodies and Parkinson's disease is really two sides of the same coin. They share the same underlying protein called alpha-synuclein. And when you look at these brains after someone passes away, they look identical in terms of what areas of the brain are involved. So as I mentioned, they're very similar. So if you look at a Parkinson's disease website like Michael J. Fox Foundation, you can find a lot of good resources. The other avenue, which is a little bit more clunky, it's sort of hard to navigate, but it still has all of the up-to-date clinical trials, is clinicaltrials.gov. That's one word, clinicaltrials.gov. And you can type in the condition you're looking for. You can sometimes sort by what type of trial is going on. So is it a drug trial, or is it a trial that's simply trying to understand the disease better? Is it a trial that's testing out a new type of imaging test in this disease? So depending on what you're interested in, you can sort by those features. Finally, one site that is relatively up to date, that has a lot of summaries that are very readable by the layperson is ALZ Forum, ALZFORUM. So that's an Alzheimer's disease focused blog, but they also have a lot of information about other types of dementias, including dementia with Lewy bodies. And so that's a site that you can go to. And if you type in therapeutics, you can find kind of a list to sort by dementia with Lewy bodies and look it up that way. So there's numerous kind of ways to do this. But yeah, I would recommend kind of any one of those three.
Great, thank you. We have a question from someone who has several relatives, a sister with Lewy body, a mother with Lewy body and with Parkinsonism, and a father with Alzheimer's. So she's wondering, what might she want to do if she wants to maybe learn about her risks?
Yeah, I think, we've seen patients at our institution who have a lot of family members who are affected by dementia with Lewy bodies, or Parkinson's disease dementia, or some other type of dementia. And we screen those individuals for the currently known genetic mutations, and a lot of times it comes back negative or normal. Basically, we don't find any abnormal mutations. But one very important caveat to that is, as I mentioned earlier in the talk, we really haven't explored many risk factors for dementia with Lewy bodies in the genome. So we've done certain studies that have identified certain mutations, but there's a big kind of vast frontier, a lot of unknown when it comes to potential risk factors for this disease. So, if you wanted to come into a clinical research setting, they can do some of those tests. But as I mentioned, a lot of times we just don't have the information to know what are all the genetic mutations that can cause or predispose someone to dementia with Lewy bodies. So yeah, it's a very timely question that you're asking. But yeah, we still don't have a lot of answers when it comes to genetics.
So maybe for now, the best bet in terms of prevention would be exercise, as you mentioned.
Yeah.
Earlier.
Yeah, exercise really kind of, if you take the example of Alzheimer's disease, so there's these genes called ApoE, and your risk of developing Alzheimer's disease, if you have both of the bad genes, is about 80%. But if you can, so you're dealt a very bad hand, essentially, when you're born. But if you're able to get aerobic exercise, you're able to dramatically decrease the risk of developing Alzheimer's disease, even if you have two ApoE4 genes. So I think the same applies for other neurodegenerative diseases, that you might be dealt a bad hand when you first are born, but there are certain risk factors like not, having a traumatic brain injury, or exercising more often, or kind of being intellectually curious and being socially involved, that are all kind of, if you can have those things on your side, you can greatly reduce the risk of developing a dementing illness.
And along those same lines, while there's evidence that it can slow or prevent it, is there any evidence that diet and exercise can actually reverse the condition?
So the short answer to that question is no. Very sadly, these diseases still inexorably progress over time. They continue to progress almost no matter what we do. However, one important thing to note is that it's pretty rare for someone to just have Lewy body disease affect their brain function. So typically people, have other factors that affect their brain function. They could be smoking, or they could be, they could have cardiovascular disease. They might not be getting the adequate oxygenation that they need to their brain. So there are certain things that we can do to our brain to sort of boost our brain health. But we can target those by things like exercise and not smoking and eating healthy. And that can make our thinking get better. But at the same time, that Lewy body disease is still going to be kind of ticking away and getting worse over time. So to answer your question, yeah, it's not going to affect Lewy body disease. It'll slow it down. It won't stop it. but it might actually improve your cognition overall because there are other things other than Lewy body disease that impact our ability to think well.
Thank you. There's another question about, you mentioned having a patient who slept 20 hours out of 24-hour period. So it sounds like this person is working with someone like that who's basically napping for most of the day and also sleeping through the night. What strategies might be helpful for someone like that, or are there any medications?
Yeah, so one of the medications that can cause sleepiness that people are frequently on with this disease is the Sinemet medication. So Sinemet is very useful from the standpoint of improving people's speed when it comes to moving, but at the same time, it can cause a decent amount of sedation. So sometimes trying to kind of get that perfect Goldilocks zone of not too, slow, but at the same time, try not to have them too sedated. Finding that Goldilocks area for Sinemet to try to, help them, maintain alertness. The other thing is just looking at other medications, making sure that, there aren't any, narcotics or, a lot of times physicians will prescribe benzodiazepines like Valium to patients to help with sleep. So just making sure there's no other medications that could be contributing. If medications, that's kind of one area. The other area is just trying to keep the patient as engaged as possible. So I know that's very hard when patients are sleeping, but keeping them in a bright lit room. Sometimes patients can be engaged with simple activities, simple visits from family members. So I know the gentleman that, for instance, slept 20 hours a day, he would wake up when family members that hadn't visited in a while came to visit him. So there are kind of things that you can modify the environment with to help patients kind of perk up a little bit. The other thing to look for is obstructive sleep apnea. So this disease frequently happens alongside obstructive sleep apnea, and that's when patients snore so much that they actually close off their airway when they sleep. So it's important to make sure that they're not snoring too much, and if there's any suspicion that they're clogging up their airway, so if they're gasping or choking or coughing while they're sleeping, it might be useful to get that checked out with a regular doctor and get a sleep test, because that can lead people to get inadequate sleep and to basically try to sleep all day. But it's a very hard thing. It's very hard to manage excessive daytime sleepiness. But those are some of the kind of introductory strategies to try to do it.
Thank you. Yeah, final question. Is there any information about a correlation between alcohol, I'm assuming like heavy alcohol use, and risk for dementia with Lewy bodies?
Yeah, not that I know of. Not that I know of. I think it definitely, alcohol is, it's a brain toxin. We know that much. People with severe alcohol abuse can have shrinkage of the part of their brain called the cerebellum, which deals with balance. And so patients with this, with alcohol abuse, as I mentioned, they can have decreased cognitive reserve. Their brain is already at a handicap. And when you add on to that brain some Lewy body disease, you get kind of, even more of a problem. So there's no direct link that I know about between alcohol abuse and the development of Lewy body disease. But if you have alcohol abuse, any Lewy body disease that's added on top of that is going to be amplified compared to someone who hasn't been abusing alcohol.
Great. One more question and then no more questions. What is the average time from early symptoms until actually like reaching a diagnosis of dementia? You mentioned that it can be decades. Do you have any sense of an average time?
Yeah, that's a question that I don't think I have an answer to. I don't think there's been really any great studies on this, but um, the problem is that a lot of times when a patient comes in to see someone like me or another behavioral neurologist, um, it's difficult to know whether constipation is just some other factor or whether that was maybe the first sign of Lewy body disease, or whether urinary urgency was the first sign of Lewy body disease, or a lot of people lose their sense of smell because of chronic sinus disease. Sometimes it's hard to pinpoint what a symptom was that was essentially caused by Lewy body disease. So in that regard, it's hard to do these studies to figure out how long does it take, in the average amount of time between when it starts and when you develop dementia. But I think there's a general consensus, though, that it does take decades to spread, especially if you look at comparative other neurodegenerative diseases where we have a lot more information. So if we look at Alzheimer's disease, Alzheimer's is caused by amyloid protein that builds up. And there's some people that say amyloid protein, based on imaging studies, we don't have imaging studies for dementia with Lewy bodies when it comes to actually imaging the abnormal protein. That's something that people are still trying to discover. But when we look at Alzheimer's disease, there's some thought that that disease might actually start when we're in our teenage years. So the thought is that these neurodegenerative diseases, they start when we're very young, and they might manifest in these very subtle ways that are sort of hard to know whether that's due to an incipient Lewy body disease, or is that just kind of a other random symptom that the patient has. But it's definitely thought that this is a disease that takes decades to eventually develop full-blown dementia.
Well, thank you, Dr. Mantyh. This has been a wonderful presentation. Thank you for answering these questions. Thank you to our participants for joining us today. As a reminder, this webinar was recorded and it will be posted on the UCSF Memory and Aging Center's website at memory.ucsf.edu, and I'll send that out to those who registered in email. We hope you enjoyed today's presentation, and we would love for you to join us next Thursday on March 19th to learn more about behavior and mood symptoms in Lewy body dementia with our presenter, Jennifer Mariles. So thanks, everyone.
Thank you.
Bye.